Good afternoon, everybody. My esteemed colleagues, respective faculty, and dear friends. It's a privilege to welcome you all to the first conference of Practicing Oral Pathologists and Microbiologists of India. I'm humbled to be here with a cohort that safeguards the patient's outcome at the cellular and microbial front lines. In next few minutes, we will align on a simple value proposition. When seconds count, basic life support saves lives. Today's session will convert evidence into action, the clear algorithms, the crisp checklist you can operationalize in clinics, labs, community settings. And my goal is to ensure each of us walks away with two things: confidence to act and ready to deploy protocol your teams can adopt on the day one. So please lean in, do ask questions, and challenge the assumptions because this is a cross functional skill set that belongs to all of us, not just the resuscitation team. Together, we will transform the bystander hesitation into a rapid, high quality CPR and turn I hope someone helps into I know exactly what to do. And thank you to the organizers for this immaculate platform and to all of you for investing your time in what truly matters, saving a life. And let's get started. Good morning. My name is Dr. Aditya Garg. I am MBBS MD. I did my fellowship in critical care medicine and then did my fellowship in pain medicine. I'm a consultant intensivist and anesthetist presently working at Gitanjali Hospital, Hisar. I'm also a director at Doctors Vibe Healthcare Services, which deal with online consultation and other healthcare home care services. I'm a certified BLS and ACLS provider. Now start with the presentation. What is BLS? BLS is defined as sequence of proceedings performed to restore the circulation of the oxygenated blood after sudden pulmonary and cardiac arrest. And fully medical care, which can be given full medical care at a hospital. BLS does not include use of drugs or invasive skills. Please pay attention. Basic life supports can be provided by even a layman or any medical professional. In ACLS, we include drugs and invasive skills. Now, what's the global burden of sudden cardiac arrest? Approximately around 7 lakh cardiac arrest occurs per year. The bystander CPR before the arrival of emergency services, it doubles the survival from the sudden cardiac arrest. Early resuscitation can result in more than 60% survival. Now, who can provide it? It can provide it by anyone, any trained medical personnel, including paramedics, and by anyone who knows how to do it anywhere, immediately, and without any other equipment. It's just a personal skill. Now, what's the use of providing the BLS, basic life support, and providing the CPR? It's maintaining the circulation and oxygenation in order to maintain a cardiac output to keep the vital organs alive. Now, what skill set it includes, or what portions we need it, in what cases we need it. It needed in cardiac arrest, it is needed in the respiratory arrest, or it needed in both the cases. Now, something about the AHA. It is a US-based non-profit founded in 1924. Its mission is to be relentless force for a world of longer and healthier lives. It leads in cardiovascular research, training, guidelines for cardiac arrest, resuscitation, stroke, and overall heart health. It is globally respected for setting the gold standard in basic life support, in advanced cardiac life support, and also in pediatric advanced cardiac life support. Now, what is the basic problems we face during dental settings or even the laboratory settings, or which the patients can have a pathology? It can be a vasovagal syncope, which is the most common occurs anywhere. It can happen. It can happen in emergency settings, even on the roadside. It can be anaphylaxis due to local anesthetic or antibiotics, for which we need either epinephrine or basic life support. Even the patient can get into aspiration or airway obstruction, like dental materials or foreign body. If suddenly patient comes over there and have a problem in breathing, or sedation-related respiratory depression, it may do occur. In oral path labs, we staff becomes the first responders because doesn't matter the doctor is present or not, the staff should also be aware of the basic life support. What should be the team dynamics? A dentist is always a team leader. In suppose you're sitting in the oral pathology lab, in the pathological lab, or in the dentist or in a clinic, a doctor, a senior most is always a team leader. Then you assign the role separately. Assistant, it can help call for help. It can go for call for help and bring the AED. AED is the external automatic external defibrillator, which I will be explaining later on. A nurse or attendant or staff can deal with the airway or the ventilation support. And importance of clear communication in emergencies always being provided and always being cared for. The communication should be clear. Always the senior most one who knows basic life support thoroughly should assign the role properly. The what should be the approach? The approach should always be the CAB. Although we say ABC, airway breathing and circulation, normally we say normal cases in the hospital setting. But in the moment the patient is on cardiac arrest or respiratory arrest, the approach turns into CAB. CA is circulation, then airway, then breathing. D is the defibrillate, which we provide through AED or ACLS team providers. It's a common acronym which BLS use to guide the providers in appropriate steps to assess and treat the patients in respiratory and cardiac distress. So compressions, airway, and breathing. What is needed in compression? It should be pushed hard and fast on the center of the victim's chest. And airway, we need to maintain first the patient is maintaining the airway or not. Tilt the victim's head back and lift the chin to open the airway. Then breathing. Earlier it was giving mouth to mouth rescue breaths. Actually, the last guidelines came in 2020 by the American Heart Association. The post COVID, the guidelines had little bit of changed, but still mouth to mouth breathing has not been obsolete right now because for your family members, for immediate near and dear ones, you can still provide mouth to mouth rescue breaths. But other ones, the mask has been advised, which I will be explaining later on. This is a chain of commands. Like early recognition and call for help should always be the best step to provide basic life support. It is to prevent the cardiac arrest. Specifically, a patient is suddenly have a respiratory arrest, but cardiac pulsation is still felt. Then early recognition and call for help is always helpful. Start with the early CPR. It is to buy time till the ACLS team, the senior most team, or any other help comes arrive. Early defibrillation, if we have the automatic external defibrillator, it is to restart the heart. Although defibrillator automatic will help in most of the condition whenever the heart electrical activity occurs vaguely. It occurs like on mostly in the ventricular tachycardia and ventricular fibrillation, which is not part of the BLS, it is part of the ACLS. And last is the post resuscitation care. It is to restore the quality of the life because early the CPR, early restoration of the blood circulation to the brain, the hypoxic injury reduces. Now, what are the steps which we need to follow? Actually, the BLS is provided for the layman, for any medical expert, anybody. We should assess the scene safety. Actually, although we are already in the pathological labs, already in the dental clinics and the hospital setup, so scene safety is already we take care of that. But still, what if any cardiac arrest happens in front of us in the roadside at home? We have to see the scene safety. What if the roadside? We have to make the patient is sick on the roads on the safety. We should not be doing CPR in the middle of the road. We should be on the safer side. Suppose there is a fire going on, a patient becomes exhausted and patient becomes unconscious. We shouldn't do start CPR immediately in the perimetry of the fire. We should first assess the scene safety. Even the pathological lab, we should make sure there is no needles lying aside. We should determine first the responsiveness. We should tap the shoulders. How are you? Are you okay? Are you okay? The patient responding or not? We should then check the carotid pulse. We should be aware of that. Being a medical personnel, everybody, we should know how to check the carotid pulse. And second pulse, we can check the femoral pulse. AHA has already recommended and safely recommended that we should go majorly for carotid pulse, secondly for femoral pulse. We should not check for radial or brachial pulse because it is when the patient is in shock, Patient BP is so low, patient is unresponsive. Mostly carotid and femoral pulse can be palpable. When if we are not able to palpate carotid pulse for next 5 to 10 seconds, go for perform the chest compressions immediately. Immediately perform the chest compressions. Then we go for open the airway, make sure there is no foreign body in the airway. Then we check for the breathing. If not breathing happen, then we have to deliver the breath. Now, how to assess the responsiveness? We should shake the shoulders, speak to the adult asking, are you all right? Are you all right? Better speak in the native language. We have to look at the chest and torso for the movement. And although normal breathing happening or not, simultaneously we have to ask for the patient if he's okay, if he's all right, if he's responding, and simultaneously we have to check the chest rise if he's breathing normally or not. It should happen within 5 to 10 seconds only. We should check the carotid pulse. We should palpate. We can palpate right now while listening to my presentation. Make sure do not check more than 10 seconds. If you are not able to feel carotid pulse, within 10 seconds, start the CPR, start the circulation, start chest compressions. That is the main motive of this basic life support. We should not stop and wait for checking the pulse more than 10 seconds. We cannot see the clock. We can start with 1001, 1002, 1003 because it's constitute 1 second. Then immediately we should call for help. Suppose if we are sitting in a room, we have two persons only, a one person becomes unconscious. We should not start immediately CPR alone. We should definitely go and ask for help because alone we cannot do CPR more than 3, 4, 5 minutes. What if we get exhausted? So suppose even if a pathological lab, a staff is alone and patient becomes unconscious, then he should immediately run towards outside, even outside the clinic lab, outside the pathological lab, to see if anybody is present over there. And they should ask for help. Because when one person comes, the next person can start with the CPR, another person make a phone call, call a doctor, senior doctors can call a ACLS team, can call emergency team, can ask for the external defibrillator, everything. Check for no pulse, no abnormal breathing, start with CPR. Shouldn't wait for anything else. Provided you have already asked for help, you should have at least two persons apart from the unconscious person to start with the CPR. With, to start with the CPR, make sure the patient position is in supine position. It is on a firm or flat surface. Suppose patient is sitting and become unconscious while you're taking a sample in the laboratory. Make sure you pick the patient and make sure it is lie on a flat surface, either on the floor or your dental chairs become flat. Kneel down to the patient and locate the position for chest compression of the person's chest. I will tell the position of the chest also. Where should you press it? We should locate the lower one third of the patient's sternum, most probably between the nipples in the midline of the body. You can clearly see the picture. It should be in the middle of the sternum, basically on the lower one third of the sternum. And also look at the fingers. We should use both the hands, and finger should be locked to other hand. One hand should be properly flat, and other should be locking the fingers like this. Or we can do it like this. If you're right-handed, make sure the right hand is above the left hand. If you're left-handed, make sure the left hand is above your right hand. Now, hand positioning, make sure see in the picture, the patient is lying on the floor. We should kneel down and we should make position of the hand, the heel of the one hand should be over the center of the person's chest between the nipples. Then place the other hand on top of the first hand and lock it. Now, one thing we have to make clear, the elbows should always be straight. I have done the ACLS and BLS workshops during my instructor phase. 90% of the even the nursing staff, even the doctors, senior doctors, they forget the elbows are not straight. They do it like this way. It should be straight. The moment your elbows become straight, you are able to make more pressure of the chest. You're able to make sure the heart is being pressed and circulation is happening. So position of your shoulders should be directly above your hands if your elbows are straight. This is the main thing in chest compression, which most of the times we forgot or we don't do it. Most of you already have done BLS and ACLS workshops in any part of the country. They always stress on keep the elbows straight. If your elbows are straight, the CPR is 90% of times is happening good. So use the upper body, make sure your arms are straight as you push straight down the chest. At least compress 2 inches, approximately 5 centimeter, but not greater than 2.4 inches or approximately 6 centimeter. Now you see how we can measure 5 to 6 centimeter. See, we just compress the chest as much as possible as down, and we have to wait and let the chest to recoil. That's the main part. When you compress the chest, you will make sure you are compressing hardly, as hard as you can. Even if you break the ribs, it is absolutely no problem. You can break the ribs. It can happen. Most of the time, ribs are broken. For older persons, if you are doing CPR, ribs can be broken, but it is not as hazardous as not doing CPR properly. If you are not doing CPR properly, not compressing the heart, anywhere circulation is not happening. Patient is already anyhow going to die. If your ribs are got broken, doesn't matter. Maximum slight hemothorax may happen. It is acceptable. But make sure you press hard as you can. Because most of us, if you elbows are straight, we press hard, hardly it becomes 5 to 6 centimeters only. I have seen the patients, the paramedical staff, the staff doing CPR, almost putting all of the weight of the patient. Still, it is acceptable in our in our medical setup. So always make sure you're compressing the heart chest as hard as possible. So always recommended, even in the AHA guidelines, it is recommended press hard and fast. Allow for the full chest recoil with each compression. The problem do occurs sometimes we are pressing so hard and so fast we forget the chest has to recoil. Because if you keep on compressing the heart will compress. But what if all of the venous circulation, which is blood circulation, which has happened all over the body, the blood has to come to the heart again. The moment you recoil, the systolic and diastolic, we have seen the heart functioning. We already know the heart functioning. The moment diastole happens, the blood has to come back towards the heart. The moment we get a full chest recoil, then again we have to compress the heart. So, and third part, allow for minimal interruptions to the chest compression. The main thing it happens is like suppose we are doing a chest compression. We have to do at least, I will tell you about 30 is to 2 compression is to be there. We wait and check for the chest carotid pulse again. Or sometimes another doctor comes, another one can, oh, what are you doing? What are you doing? We shouldn't be doing anything communication with everybody. We should keep on doing chest compression. We can keep our mouth open. We can continue with our assessment of the patient. We can say, oh, this happened, but your chest compression should not stop. It should be non-stop chest compression. Non-stop chest compression should happen. It should be hard and fast, and we should make sure the chest recoils with each compression. This is the three things we have to make sure, and 60 to 70% patients recover very well. Very well, they recover well. Means they don't have most hypoxic injury post resuscitation. They recover very well, and most of the time, even they become conscious and they can keeps on walking also. They start walking after doing good chest compressions. I've seen it. It happens roadside. It do happens. So we have to deliver at least 30 chest compressions initially before delivering one breath. We have to count it loudly, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. If we count it, we know what we are doing it. If we don't count it, we always miss the chest compressions. Or we either doing it slow or we're doing it very fast, so we are not counting it. We should count it because the person who is standing over the airway side, he knows he has to give the breaths. It's 30 is to 2 compression. After 30 chest compressions, we need to give 2 breaths to make sure the airway is clear. two breaths should be given. If you are not counting the person who is standing over the head, over the airway, who's providing the airway support, he doesn't know like at what time have to compress the embu bag or what time have to give the mouth about breathing even for the family members. You have to make sure that you have to count it loudly. Or suppose we are not able to count, if we have to do one or two person and other person is not able to provide the airway support, go for 100 to 120 compressions per minute. You can, this happens via regular practices. The push hard at the rate of 100 to 120 compressions per minute. We have to make sure chest compression should keep on continuing, provided at the time of breaths, two breaths, we can make it stop, or just for 2 seconds, then immediately again start for chest compressions. Now, it shouldn't be not too fast or not too hard. Now you said press hard and press fast, but not too fast. But it shouldn't be 200 chest compressions. It shouldn't be that too hard that it compresses the chest but doesn't make recoil. Press hard, press fast means 100 to 20 breaths per minute, 5 to 6 centimeters deep, and non-stop interruptions. But not too fast, it doesn't become 200 compressions per minute. And not too that hard that you are compressing it, but chest is not able to recoil. It comes with the practice. Or start with the mannequin. Although we have an online conference, next time we meet for the practical conference, I will make sure we have do ACLS and BLS training together, and I will make sure the practical how to do it chest compressions. Even early as early as possible, I will make video available to you to everybody in even in the POPMA our WhatsApp group to how to do it as fast as possible and not too fast and not too hard. But press hard, press fast definitely is the motive. So again, after 30 chest compressions, we have to make sure we have to assess it and establish the airway. This is like after 30 chest compressions, while the other person is giving the two breaths, make sure the person who's doing chest compressions, he can check over the carotid pulse at that time or check over the femoral pulse. It is recommended by American Heart Association always give two rescue breaths, each lasting for just 1 second. Assess for visible chest rise with each breath. So 30 is to 2 means 30 chest compression after counting 1 to 30. The person on the airway side has to give two rescue breaths, each lasting for 1 second. And that person who's giving the breath should also check for visible chest rise which is happening. Because if we are giving by mouth to mouth or if we have the mask which is being shown in the picture, what if the chest is not rising? Then we are not giving the proper breaths. We are not definitely not giving the proper breaths. So person not giving proper breath, proper oxygenation is not happening. So there's no use of giving the breaths. The person who's doing chest compression at that time can assess the carotid, can assess the femoral level, but make sure the visible chest rise. In the picture, you can also see the face mask, which we can kept in the pathological labs, which we can kept on the dental clinics, in all hospital setups, even at home also. So we are not able to provide mouth to mouth breaths. We are not comfortable with providing mouth to mouth breaths. Then definitely go for this mask. And I will recommend post COVID, do give breaths with this mask only. For the clinical pathological labs and for the dental clinics, better keep embu bag with you. You don't even have to give them breaths with the mouth. You keep the mask over there, you compress it, embu bag. Oh, I hope everybody knows what embu bag is. Now, after giving 30 chest compressions, we have to make sure victim's airway is open. There are two maneuvers to open the airway. Head tilt, chin lift maneuver. Head tilt is we have to make sure the head is pressed down and we have to make sure chin is lift. Because what if chin lift maneuver helps to make sure the tongue doesn't stop, hinders in the airway process. After chin lift maneuver, the tongue becomes assessed to a lower part of the jaw and airway becomes open. So It's easy to provide the breaths to the patient. Head, tilt, chin, lift maneuver. We can chin lift, do it also from the angle of the mandible. From the angle of the mandible, we do it like this. The chin is lift and head is tilted up. Then it 90% is possible. The airway is open. Second is jaw thrust maneuver, which I have said it. It is the jaw thrust maneuver. I cannot show it right now. It's we do it during our anesthesia practice and intensive care practices. The patient is not opening her mouth. Patient has tight. Patient is having seizure activity. Then we usually do it jaw thrust maneuver. Uh, it is provided when we are not able to do head tilt chin lift maneuver because suppose there is trauma on the roadside accident, we see the patient is unconscious and there is visible injury mark over the neck region, so there is possible cervical injury happens, so we never do head tilt position over that time. At that time we do just jaw thrust maneuver, so airway becomes open. We do it like that way. So make sure the spinal cord injuries not happen. It's already, although it happens very less time, very less number of cases. So you can do it in 99% of cases, head tilt chin lift maneuver. If you're not able to do it, go for jaw thrust maneuver. So what is the methods of rescue breaths which is recommended by AHA? First, mouth to mouth breathing only for real and near and dear ones or the family members. I would personally recommend, not for everybody. There's also mouth to nose breathing or mouth to stoma ventilation. Mouth to nose breathing is we are not able, patient is not able to open his mouth. Patient is having seizure activities initially and patient becomes unconscious and carotid pulse is not being felt. Then go for mouth to nose. Then mouth to stoma ventilation is suppose patient is already having tracheostomy tube over there. Tracheostomy tube over there, they can directly give airway breathing to the tracheostomy tube. There is ventilation with bag and mask. Like this is the ambu bag, which shown in the right lower portion of the picture. This is the ambu bag. We provide the airway with bag and mask. Better, I would advise everybody to the clinical pathological labs and the clinical settings. We should keep one ambu bag with you all the time. Or last is ventilation with advanced airway, where we intubate the patient and directly provide the mechanical ventilation. There is technique. If we suppose we have a mask over there, we cannot directly compress the mask over the face because it will help nothing. It will won't help you provide the breaths because if you directly compress the face mask over the nose and mouth over there, it will not help to clear the airway. So there is a special thing we can help. Bag and mask ventilation will be more helpful and it can be done with one hand only. See the position is C and E shape. See, face of the mask with patient before attaching the bag, use non-dominant hand. Create a C shape with the thumb and index finger over the top of the mask and apply gentle downward pressure to make sure there is no airway leak. And hook the remaining fingers around the mandible and lift it upwards towards the mask and creating the E. This C and E, it is being told to us, being to our first year postgraduate anesthetists and all emergency medicine anesthetists, emergency medicine PGs, to C and E. So it will help to make sure the no leakage of airway happens. The and also the head tilt chin lift can be occur by creating the E also. See, C and E, it helps to cover the nose and mouth with the mask without extending it over the chin and change the size of the mask as appropriate to create a good seal. It mask can be changed if we are already in the hospital setting and patient become unconscious. Otherwise, whatever mask you have provided with the breaths plus chest compression should continue beforehand. So again, I'm repeating it with each rescue breath should last approximately 1 second only. Watch for the chest rise and allow time for air to expel from the patient. Do have to give the time for the air to expel the patient. Now you will ask, like we are providing mouth to mouth breath, we are not giving oxygen. So how we can make sure oxygen be given? Still, if we are giving our own breath, majorly it is carbon dioxide, still contains oxygen. It's definitely still contains oxygen. So we should go for mouth-to-mouth breaths only to near and dear ones. and we should make sure we are giving rescue breathing after 30 chest compressions. Still continue CPR. After giving two rescue breaths, we should continue with the CPR. If two providers are present, switch roles between compressor and rescue breather every 5 cycles. Every 5 cycle means 30 is to 2. 30 chest compression, 2 breaths given. 30 chest compression, 2 breaths are given. Then 30 chest compression, 2 breaths are again given. Suppose we should make sure this is 1 cycle. 30 is to 2 is 1 cycle. It is considered by American Heart Association. 30 is to 2 should continue minimum of 5 cycles. Now, suppose a person providing chest compressions become exhausted, become tired, and become fatigued, and not able to provide chest compression. He should stop it. Other person should provide with chest compression because we don't want another unconscious patient. One person already unconscious, already he's dying. We are providing chest compression. We're helping that patient with CPR. But the person who is providing with CPR shouldn't get exhausted that much. Even if you will get tired after 2 cycles, stop it and ask for another person to do chest compression, or you change the position. I did recommend it to switch roles after 5 cycles, but you can change the position even after 2 cycles because rescue breaths, the person providing rescue breath is being at rest. He provides only 2 breaths after 30 chest compressions, but the person doing CPR become exhausted. So we should continue resuscitation. Up to what time we should continue resuscitation? We should continue until unless qualified help arrives or takes over you. Qualified help means ACLS team arrives. There is ACLS team being designated ACLS team in every hospitals, you know it. Or either till victim starts breathing normally, you can see, or the pulse, you are feeling the pulse. If you're feeling the pulse, the breathing is happening, then okay, you can stop the CPR. Or rescuer becomes exhausted, which I've already explained. If you're exhausted, you're only two persons with the patient. If you're exhausted, don't do CPR. Don't do CPR because one person is already dying. We don't want another person to become unconscious. That's the main motive. We are helping that person. We don't want two patients until the another help arrives. So 1 cycle is, again, I'm repeating, adult CPR, 30 chest compression to 2 rescue breaths, perform 5 cycles of CPR, which approximately lasts for 2 minutes. You can see like 120 chest compressions occurs in 1 minute to for 2 minutes, around 200 chest compressions for 5 cycles, 150, 200 chest compression happen. That's widely accepted. Now, automatic external defibrillator, which I have mentioned earlier, it is an external device. It is automated device that has ability to detect irregular heart rhythm. It automatically delivers the defibrillation shock to stop the irregular heartbeat and allow normal rhythm to resume. It is designed to be used by any layperson. So usually when ACLS team arrives, we have a proper defibrillator, which we provide shock after seeing the rhythm of the patient or ECG, which if you want, I can take ACLS class also later on. But in automatic defibrillator, we just have to attach the pads. There is a proper mentioning pictures being depicted over there where to attach the pads, and we own it. That's it. It will automatically assess the heart rhythm. It will assess the electrical activity of heart. And suppose the patient, while doing chest compressions, it will automatically say, wait, there's a proper speaker inbuilt. You can say GPS system in between. The lady will speak over it and it will say, wait, I'm assessing the heart rhythm. If the patient is having ventricular tachycardia, because more than 50% of cases, upon patient we are doing CPR, patient becomes the heart rhythm can go into ventricular tachycardia or ventricular fibrillation. Patients having ventricular tachycardia, then automatically assess the rhythm and it will say, I'm giving the shock. Please clear it. And it will automatically deliver the shock. So you can see in the picture clearly, we have to just attach the pads to the patient's bare chest and provided the chest compression shouldn't have been stopped. If one person is doing chest compression, if you have AED with you, AED is usually with the big setups, and you most of you might have seen it. AEDs available with the emergency department, so that's big setups. Another person should attach the pads. One person who is doing CPR should continue with CPR. because we are doing chest compression on the middle of the chest, on the lower one third of the sternum. Still, rest of the chest area is being bare where pads can be attached. Suppose AED says it like patient needs a defibrillator shock. Make sure you clear from the patient. And it has to be verbally, loudly being spoken. I am clear. Are you clear? Then person will say all clear. A team leader who is not doing chest compression, the other person is chest compression. We have to make sure all rescuers should not touch the patient at that time, because I have seen one of my staff while we were giving the shock is transmitted to that staff, and staff become unconscious. Although he revived very well within 2 3 minutes, but still we have to make sure after attaching the AED, you should do the chest compression together. When the AED machine says it, I'm giving the shock, please clear. We have to make sure you should not be touching the patient. Even the rescue breather who is giving rescue breath should not touch the patient. Now, we have done everything. The patient started breathing normally, or patient is becoming conscious slowly. We have to make sure the patient is in recovery position. Why recovery position? Because we are doing chest compression. We don't know patient has eaten anything or patient has drink something, even simple water, and an unconscious state, patient can vomit. We are doing chest compressions, and unknowingly we have pressed the stomach also. Patient can vomit, and in semi-unconscious state, patient is breathing normally but still slightly unconscious. Patient can aspirate the contents of the vomit. So we have to make sure the patient is in recovery position. And how to do it? Suppose you are two persons only. The patient is big. You cannot turn on the patient alone. So make sure you make the one hand towards the left hand of the patient above the shoulder, and another hand touching the left hand of the shoulder. You can clearly see the pictures one, two, three, four, and then make sure the leg of the opposite side of you, it should be folded towards from the knee side, and you turn the patient. And it's easy. The recovery position, even the small 40, 50 kg person can make another person into recovery position alone, and patient being 90 kg. And I've seen it, and we do it regularly in our intensive care setups. Even the young female nursing staff can turn the patient alone in our ICU. We do it regularly. The patients who are in ventilator support, we have to make sure that every 2 hour position is being changed so that patient doesn't get any bed sore. So it's easy recovery position, but make sure you follow these steps. It's very easy. Then now the complications of CPR. Complications do happen with CPR, and it may happen, and doesn't matter. But CPR should continue. What may happen? The ribs can get fractured. It do happen. And today morning itself, I have done CPR to a patient around 80 or female, 3 4 ribs and fractured. Unfortunately, she revived. And it's true. Like almost I do it every alternate day. CPRs in the ICU setups. So ribs do can fracture. Doesn't matter because it may cause hemothorax or blood retention in the mediastinal space. Doesn't matter. CPR should continue. Internal injuries to organs can happen because sometimes we are not compressing the sternum, we are starting compressing the stomach, or we're starting the side of the ribs where we are not, because rib fracture usually happen near the sternum side, and we are compressing the chest over the nipples of the side of the chest. Then ribs fracture can happen of the middle of the ribs, and it can injure the lung. So that shouldn't happen. That's why it is recommended always compress over the sternum. So even if rib fracture happen, it happens only this cartilaginous part which is attaching to the sternum. So laceration related tip of the sternum, it can happen sometimes. We are all on the lower part of the sternum, over the Ziphy sternum, and we are compressing the chest. And suppose the patient is very bony, a patient is having COPD chest. So COPD patients have a bony pigeon shaped chest, and the sternum is very much prominent. Even the tip Ziphy sternum area is very prominent. It's rarely reported. I haven't seen it in my personal life. I haven't seen any laceration happening. Vomiting and aspiration, it is very common. The patient become conscious, patient is recovering, patient is breathing normally, immediately patient starting vomiting and say aspiration do happen. That's why it is recommended to make sure the patient is in recovery position at that time. The moment patient recovers, make it that person shifted to recovery position. Gastric distension happens. Gastric distension sometimes happen. You are giving rescue breaths. It is not going towards the lungs. That's why it recommended the moment you give rescue breaths, make sure chest rise happen. If chest rise is not happening, your air is going towards the stomach and gastric distension happens. And more air is going towards the stomach, not towards the chest. It can lead to vomiting and aspiration later on. So make sure every step, everything is happening as per recommended guidelines. So the complication doesn't happen much. But complication do occur with CPR, doesn't matter. We have to provide with the help. So what is the take home message? Taking the right action quickly, confidently can make the difference between life and death for a person dealing with the cardiac arrest. I hope I'm able to explain to you fully. I'm able to explain to you everything, and still something is left. I'm always ready to help you. Always ready to help you. If you have any questions or anything, I'm ready with you. Thank you.